today as our first webinar of the new year. Happy New Year to everyone. I am Ren, and I'm really glad to be co-hosting this session with our Chief Medical Officer, Dr. Christophe Correll, who hardly needs an introduction. He is one of the leading voices globally in measurement-based care and in psychiatry. Christophe, before we get started, what is the main focus for us today?
Well, first of all, a Happy New Year from me too, and it's great to have our first webinar to really showcase some of the developments in psychiatry that we want the audience and our listeners and viewers to see, also obviously related to what we're trying to do in MedLink Global. And since MedLink Global is trying to improve, if not revolutionize, mental health care, we can only do this by regulating input of information to hone and have more precise output. And that means, what do we come up with as a diagnosis? And based on that, what do we then use as a treatment? And when then the response of the patient comes back, we can recalibrate the whole thing. Usually what we do in medicine is we measure things. Well, it's basically the centimeter diameter of a spot on your skin, or whether it's blood pressure or pulse. It's obviously much harder in psychiatry, but we must become more of a medical specialty. That's why we'll be talking about measurement-based care, but not just as a theoretical concept. Can we actually apply it? And where it has been applied, is it actually useful?
Sounds great, and it sounds like we have a lot of great material to cover today. Psychiatry is such a unique field in terms of measurement, and I have been questioned by so many people from different industries saying like, okay, what you're building, sounds or looking reasonable, but how, right? Great, let me start sharing my screen. Can you see this?
Yes.
Okay, please let me know if I go next page.
Yes, so why don't you go next? I think next one will be my disclosure information. Today, we'll talk a little bit about medication, but not in the context of specific efficacy. It's more like how you apply it. Next slide. So we'll talk about general principles of measurement-based care and use two examples of applied measurement-based care. One is in major depressive disorder, one is in schizophrenia. Then talk about barriers, opportunities, and alongside talk about some of the tools. Next. Yeah, so that's the problem. How do we calibrate the brain? Because the brain is behind our skull, and our thoughts and feelings are difficult to discern. It's all very subjective. What we do have more of an objective handle on is the behavior, because emotions turn into behavior, thoughts turn into behavior, motivations turn into behavior, but we can also conceal them, and especially in disorders like schizophrenia, where people might feel distrustful, they may not actually tell you the truth. They have anosognosia, they may not know the truth that they're sick. So let's talk about general principles then. There's value, but there are also barriers. Well, because, it's why don't we use measurement in psychiatry? Well, it's complex. First of all, the value is that we get information that is more scaled and also more objective. Now, obviously, you need to find the right measurement in order to do that. We need information to have a diagnosis. That's why, for example, at MedLink Global, we use MINDS, M-A-I-N-D-S, where patients fill out lots of questions that help us grade their symptoms, self-rated, on different dimensions. And that is, for example, internalizing, externalizing, or thought disorders. And by filling out these scales, sometimes patients are a little bit more honest than telling you into your face. So I had a case that actually was presenting to MedLink Global for a private consultation, where nobody knew why she was going off the deep end. But when we looked at the MINDS, it became clear she lit up mostly on the PTSD side. So there must have been trauma. She didn't talk about it because she was very embarrassed. So getting measurements, and that's both observation from caregivers or friends, self-observation, self-report, but also then the clinician putting it together can be very helpful for the diagnostic process. Looking how severe the patient may be impaired in certain domains, that could be symptoms, but also functioning. And then also having treatment targets where we can develop the treatment goals and then match that to the chosen treatments that ideally are chosen in a shared decision-making process. But even for shared decision-making, it's helpful to feed back to the patient what might be going on. When you're in the midst of a crisis, you have emotions, you have thoughts, but you can't necessarily put it together unless you've been sick before and you've had the diagnosis. So using the measurement in order to show a patient this is what's going on can be in itself already be therapeutic and can help us also to provide psychoeducation, which is the first step in any approach toward healing or treatment of mental disorders. And then measurement goes into also not just at baseline what's going on, but as I said before, moving forward, what's the feedback in terms of efficacy, but also tolerability. And documentation is also very important. You can also remind the patient who may feel nothing changed, I'm still depressed. Well, wait a second, last time your PHQ-9 was a certain number and now it's actually 4 points lower. But even if you don't use a PHQ-9, you can use, for example, what I use a lot, on a scale from 0 to 10, how depressed are you now? And it might be an 8 out of 10. The next time they say 6 out of 10. But it's also logical. Why are we even having a whole session on this? Because of the right-hand side of this table. There are barriers. First of all, clinicians feel, oh, numbers is not my intuition. I'm a great clinician. I perceive things. It's gut-based psychiatry. I have it here in the patient too. Also, inadequate appreciation of feedback in a more measurement-based fashion. And that then translates into over-evaluating the time you might have to spend in collecting the data, interpreting them, and feeding them back. Because if you feel it's not helpful, then why spend time? But you can actually, with this small investment, save a lot of time on the back end because patients have better outcomes, as we will see. But also lack of appropriate instruments. We have this huge gap between research, where we have lengthy scales, where we have people trained and getting paid to do it, and patients getting paid to also participate. But it's totally useless in clinical care, where we need a very quick but also valid and scalable scale. Scalable means you can use them across multiple settings. And then there are also reimbursement constraints. But actually, the insurance companies in the US are waking up to the fact that, maybe paying for a little scale is quite an investment that's made on a larger scale because people are less admitted and less need less care and is less expensive. Next slide. So let's talk about major depressive disorder as one of the most common disorders in life. About 20%, next slide, will have at lifetime. And this is a study actually conducted in China that I was fortunate to participate in, where it was a very simple design, but actually made it into the American Journal of Psychiatry, where we had 2 teams treat people with depression. And the one team just did usual care. They had to be constrained to 2 medications, though. That's good because then you have the same medications in the measurement-based arm and in the usual care arm. So in China, they like more sedating drugs, apparently, because maybe insomnia is an issue or anxiety. So it was either mirtazapine or paroxetine. So paroxetine an SSRI or mirtazapine an ASA, where you also have noradrenaline increase, but histamine blockade at lower doses. And so they could start with one or the other, and if it didn't work in usual care, you would switch. Either it didn't work for efficacy or safety. So the only thing we did on the other hand on measurement-based care was giving the patient 2 scales to fill out. One was an efficacy scale, where they actually rated how depressed they were, the QIDS, which is also the scale used in the STAR-D. And the other one was a side effect scale, how much side effects they had on certain levels. And here we go, exactly, thank you. We use the STAR-D developed QIDS, and then also that's the 16-item self-inventory, and we had the FIPSR, the frequency, intensity, burden of side effect rating. And so each time that the clinician came back, the patient came back to the clinician, they had this rating, how severe is the depression and how severe are the side effects. So that's the first thing, that's the input. But the second part, which was, I think, equally important, if not more important, was we had a very clear schedule. You better drive up the dose until you either had efficacy or safety problems. And I call this ow or wow. That's how I dose in clinical care too. So I go as high until I'm satisfied with the results on the efficacy side, or I have to hold back. So that forces people to actually explore the whole dose range, but also when you have too many side effects or you have explored the higher dose and don't get efficacy, now you switch because your goal is remission. That was the goal on the efficacy, not response. Symptom reduction doesn't help us. We want the symptoms to be low. All right, next slide.
So
With
Chris,
this, yeah.
sorry, Dana, I have a question about this study. So, what do you think is like making this self-report, like two self-report measure work so well in this study compared to like clinician judgment alone, like just assuming without it?
Yes, so I think there are multiple reasons. One is we don't ask all the potential questions for time or also for bias. You only ask, are you depressed? That's one item. Have you had any side effects? And then you get a recall bias. I feel depressed now. How have I been in the last 6 days? So having 16 items for depression gives you a much broader range. And the patient is reminded, oh yeah, you're right. I had this. That's number one. And for the side effects, the same. If you're going systematically, you get much more in terms of the side effects. And then also, how impairing was it? How severe? So it's the comprehensiveness, it's the scaling, and it's also the relevance of those items that are tailored to the medication and the illness.
Got it. And when you talk about the dosing that your preference is increasing high enough until, because the goal is remission, right? And I wonder, in that case, would you say like measurement-based care primarily reduce more cases of under treatment instead of over treatment?
I think more under than over treatment because we're going for efficacy. And the biggest mistake, I think, is keeping people on medications that can cause side effects and they are not beneficial enough. Now, obviously, you need to make sure that patients are taking it because the biggest reason for not working for a medication is not being taken as prescribed. Now, over treatment is more on the side effect side. That's usually what patients tell us. Doc, I hate this. And they take it into their own hands. But they don't take it in their own hands to increase the dose or ask for a change as much if they have still residual symptoms. And depression is 80% treated by primary care physicians that make the biggest mistake of low dose and then they keep it there. So this our approach in clinical care, which is reinforced by a fixed force titration. Here, you go up every 2 weeks with paroxetine and every week with mirtazapine, and then you check where you are, actually, I think, had the tripod of success: measurement, force titration, and checking your results that then determines whether you go up on the dose, keep the dose where it is, or switch.
Sounds good. And imagine there's a world, everybody has the measurement, like different scales in their hand as clinician, doesn't matter, primary care or psychiatrist. Do you think this structured measurement can change the prescriber behave in practice?
Well, if they believe in the measurement and use it because they want to apply it, absolutely. The problem is we have some measurements, but they're not widely adopted. People don't believe in them. They're not integrated into their workflow in terms of medical records. That's where Medline Global, again, has tools to do that, which is, I think, easy. You just click on something, you get it, and then you can determine your next step.
Got it. Well, I'll move to the next.
Genau. And this is the results. It's just amazing by using the same medications and just having a little bit of feedback, knowing that you have to either go up when you haven't reached your goal or stay where you are when you have, that's remission, or switch when you haven't reached your goal once you've had the most tolerable dose, or you have to switch for intolerability. Here it is. So you have basically 90% response. That's a 50% reduction in the QIDS versus 63%. The number needed to treat was 4. That's amazing. Basically, after each 4th patient, you have 1 more responder, but it gets even better. The response and remission were very close together. It was basically 87% versus 74%. So 3/4 of patients with this measurement-based care-based approach reached remission, which is being below the clinically relevant threshold on the QIDS, and that's only 10% or 13% lower. Whereas you see this drops to less than or almost a third in the people who are treated only partially in the usual care arm. There it's only 29%, and here the number needed to treat is almost 2. So you get even doubly as good, twice as good for the goal that we want, and that's remission. And it's understandable because we pushed people to reach remission or move on with a dose or with a drug. Whereas clinicians are often happy enough when there's a reduction in symptoms. So that's a big lesson. Setting your goal and having your eyes on it, but also measuring it can help you reach the goal.
This graph looks amazing because it looks like we're not only reaching the goal, but also changing or fast forward the trajectory of the goal.
Apropos fast forward, and thank you for mentioning this, this is not only, if you go, yeah, no, here it's good. Yeah, you can see it visually, but on the next slide, you see it even in time. You reach the goal faster too. So next slide, you can see you're not only reducing the number of people who are suffering, you're also getting there faster, even if people get it in the usual care. So the estimated time to response in the standard group was 9 weeks, and that was, 11 weeks, almost 12 weeks, 3 months, and that was cut in half to 5.6 weeks. And to remission, it was, when it was achieved, if and when it was achieved, it was 20 weeks compared to 10 weeks. So you're cutting also the duration, even in the people who are successful. So I was really flabbergasted when I saw these results, and it just tells us we need to use measurement-based care.
Yep. It will not force you, but really encourage you, give you the confidence of either make a change or make a change.
Yes, right, and have the information based on which you make a change, wow or ow. All right, let's move on to the next one, and that's schizophrenia. Here it's a little less clearly outlined what the goal should be, because self-report in schizophrenia, and we're doing a big review right now on that, is tricky. Patients may not be as aware of their positive symptoms, their negative symptoms. We might need triangulation, but we have clinician ratings now, and I will show you what we've developed, a shortening of the PANSS, which has 30 items, that can actually be used in clinical care. So let's move on and look at the RAISE study, Recovery After an Initial Schizophrenia Episode. That was a $28 million study funded by the National Institute of Mental Health, following on the heels of the not so successful study, which was called CATIE, published in 2005 in the New England Journal, where 1,492 patients were randomized to 5 different treatments, a first-generation agent, pirfenazine, and 4 second-generation agents, olanzapine, risperidone, quetiapine, and ziprasidone, which came later. And the idea was, yes, second-generation agents are better than first over basically a sequenced approach. The first had a comparison of these 5 agents with subgroups. I will not bore the audience with that information. And then non-responders moved on to a clozapine or a side effect study, and then phase 3 was multiple treatments. But these were outpatients who were chronically ill, and the results overall were like, on a mean, was 14% reduction on the PAN, total PAN. So not great. So NIMH said that was a $58 million study. All right, let's have now a first episode study. We've shown it's maybe too late in chronic patients, and they created a call for RAISE. And the idea here was change the illness trajectory from the first episode. But by the way, do it in the current reimbursement setting, which is not that great in the US. So we were basically asked to dance while we were tied up. And so our idea was, okay, if we have to do this, we have to do it in a real world. We have to do it in not randomized by patient, because we want to see that this works in small clinics. So we did cluster randomization. We randomized sites where we trained them on our program, which was called Navigate. You have to navigate the illness, and that was psychopharmacology was one arm, one element of it, but there was also needs-based intervention and strength-based psychotherapy, psychoeducation, and so forth. And then we randomized these 40 sites or so in 21 states. But we have now the problem, how do we, with a time constraints, get all of the assessments. So we did centralized assessments with two-way video. That was one way of doing it, so that we didn't have to train the sites. But also we needed to give the Navigate group versus usual care sites a compass to navigate. So in the compass was assessment of symptoms and also outcome, which we could then tailor our interventions on. And that was our Navigate tool. But here is the 400 patients, 16 to 40 years of age, less than 6 months of treatment. That was the definition of first episode. And they either got Navigate or they got usual care. And the treatment follow-up was at least 2 years. The primary outcome here was quality of life. We had a long discussion about that, believe me, because, well, what about symptoms? What about side effects? What about functioning? But we felt all of this went into quality of life, but we measured the rest too. Next. These are the 34 sites in 21 states, so we wanted to be distributed. Next. And this is the team-based approach where we had shared decision-making. I mentioned strength and resilience focus, psychoeducation, motivation enhancement. But the 4 components were Compass, our psycho-farm, the individual resiliency training, family psycho-ed, and supported employment and education, because we felt all of this would coalesce on symptom reduction, better functioning, and outcome. Next. But in order to navigate, you need a compass. And the compass was this shared decision-making model where we had web-based application on desktops and laptops or iPad, where patients filled out, it was a lengthy questionnaire, but whenever they came to the clinic, here it is, they would put in what their symptoms were they suicidal, did they have side effects, they were also weight, whether they had weight gain. And then when they met the clinician had all this map already in front of them. They didn't have to ask 100 questions. They asked maybe 5, where, oh, you said you didn't sleep. There was nothing on maybe substance use or suicidality. Let me focus on sleep. And with that, they could be much more targeted, and also had like a severity of this. And the patient felt recognized. Oh yeah, you know that I didn't sleep. Let's talk about that. And based on that, there could then be a treatment approach. Next slide. And this was also visualized. So that's the good thing when you have such a platform, you know, oh, I changed my medication, I upped the dose here of citalopram, and actually the PHQ-9 goes down. Now, this is schizophrenia. This is just an example from STAR-D, where you can have the longitudinal assessment. So you don't have to like go through your notes. You already know what you've done, and you can see what the patient's response has been. And using this approach, next slide, we actually were able to show, next slide, that patients who got Navigate, were on medication longer and had less side effects. That's pretty good, because we were able to tailor the medication using a lower risk medication first. When they didn't take the medication, they could switch to an LAI and so forth. So we were able to get better adherence even, because patients felt recognized, oh, you know whether I'm doing better, whether I have side effects. And they were also, despite having more medication, less side effects, because we tailored it to their well-being. And that's obviously a good win. Next. And with that, we also, well, the outcome was, yes, Navigate won over usual care or community care, we called it, on the primary outcome, quality of life, but also on symptoms and all the rest of it. But we had to use in that study also the total PANSS. That's a 30-item problem for research. That wasn't what the patient filled in at much lower frequency than the clinical visits, baseline and 6 monthly. We also did the PANSS. So we couldn't use it for patient-clinician encounter. So here we worked with Søren Ostergaard as the main driver of this, and Mark Opler, who is the son of Lou Opler, and Lou Opler actually developed the PANSS 30, died a couple of years ago. We thought we need something that's usable in clinical care, and that's the PANSS 6. So we didn't create new items. We just looked at the 30 items in different studies and actually asked ourselves and the data, is the PANSS scalable? Meaning, are you even allowed to put the 30 items together, divide them and subtract them and have a mean score? And scalability actually means that you measure what the scale is supposed to measure, and that it makes sense on a population basis. That means if you have a lot of, or a high frequency of symptoms, they can't all be severe, because then patients couldn't walk around. So the more severe symptoms should be less frequent in the population, and the more frequent ones less severe. And we were able to show that PANSS 30 is not scalable. You shouldn't even put it together. PANSS 18 or 14, which have been proposed, are not scalable. PANSS 8, which is the Andreasen criteria for remission, where you have no more than mild symptoms on positive and negative items, also is not scalable, but PANSS 6 is. Next slide.
Sorry, Christoph, before we dive into the PANSS 6, I really find the race study is super interesting, because especially the COMPASS share a philosophy that at MedLink Global we all believe, seems like, and then and it's a very successful study with a great result. And I have a couple of questions immediately seeing this conclusion here. So do you think, because it's a well-designed study, do you think this decision sharing and team-based care play a huge role there versus the measurement-based care that is obviously also important, but the success you would say is due to the measurement-based care versus the shared decision-making model? And what if we take out the measurement-based care? What you would expect in this study?
Yes, so that's a big criticism of the study, that we had to put everything together, all the elements of the care, which is different psychosocial interventions, pharmacology, shared decision-making, family psychoeducation. So we don't know which element actually did what. But I didn't add here the primary outcome or the secondary outcome, which was quality of life or reduction in PANSS score, because that's most likely also related to the other elements of care. Here we have things that are really related to pharmacological outcome, where this COMPASS actually was used for the medication choice. So in that sense, I think the measurement played a very big role. But without shared decision-making, patients may say, oh, you tell me, but I don't take it. So in that sense, I think just doing measurement without having also the patient feeling that they are part of the decision process and that we're actually tailoring the treatment to their goals and needs and preferences, it wouldn't work. So it's not an isolated tool. You're entirely right. It needs to be combined with other elements of good clinical practice.
And the COMPASS, it was almost 6 years ago, right? Looks like a super advanced idea there, that you help the clinicians to decide what are the safer medication or the better suitable, more personalized to this patient needs. And do you think, of course, that is pre-AI era, right? Now we can do it even more smoothly, more intelligently. And in terms of this decision-making support tool, as a clinician and researcher yourself, do you think where usually draw the line between support and automation, or how clinician feels about it?
Yeah, a very good question. First of all, we wanted this to become a tool that's marketable, and it totally crashed. We couldn't integrate it into a medical record, and maybe we didn't have the tools. We were in the startup, and also the field wasn't as advanced. So now with AI, I think it's more doable. So this would have been great, but it's totally now archaic. Yeah, so sitting in front of a computer. So basically, I think we're now in a position to do it. And everything in life is on a dimension, correct? And you may have to tailor also how much automation and how much physical coaching or contact there is with a person. That depends on the patient, the disease, the clinician, the preference on both sides. We have to be careful to be extreme. It always has to be a person, or it should all be automated. So maybe we have to have a feedback system. How happy are you now that you've talked to the AI agent? Is that enough? Or when you have a chatbot therapy, do you need more? So that you can up and downgrade the human condition and the human component, I think, is important.
Yeah.
So this needs to be flexible.
seems like also very important, so the clinicians still feel the power that decision is me, to make. You give me the suggestion, but with very transparent evidence there, so that I can think and make my own decision. Well, thank you so
Very important, because I mean that's the fear right now with automation, that the automated system says one thing and the patient dies, and it made a mistake. It hallucinated a drug or a dose or whatever. So we need some human control, but humans also want to be in control, but we need to facilitate that decision making and make it more qualitatively sound with all of the information we can't have online, even experts. And that's what Mentra does, which we haven't talked about, what we're building right now with the support of Mayo data from the Mayo Clinic. We're feeding both the broad knowledge base of books and references and studies, but also real data and patient trajectories, so that we can say, well, for a patient who has XYZ, both demographic, illness, and treatment history, now this is the best path, so that we can suggest that here is the textbook knowledge, here is the likelihood of success based on what we know in this set, real world, and not just RCTs, but real world data in a clinic where you actually reside, or in a clinic that is similar to you. And that's what Mentra will be, and hopefully soon can be linked with Minds and also Delphia, our automated intake and also assessment agent, so that the clinician and the patient both feel very empowered to make the right decision at the right time.
Right. Well, thank you so much. Let's move on back to our PANSS.
Yes, so that's PANSS. When you let the data decide, it could be very disappointing, and you don't get the core items of a disease. So we asked which symptoms of the 30 on the PANSS actually are scalable and capture most of the variance when you treat people in an acute setting and a chronic setting. We used also KD data, and fortunately, it was the right symptoms. It was 3 positive and 3 negative. That's great, because you're split evenly. We think those are 2 important domains. And it was the right positive ones that we always ask and worry about: delusions, hallucinations, thought disorder. That's defining for even making a diagnosis of schizophrenia. And then we had 3 negative symptoms, which is the 2 expressive ones: alogia, not talking much, affective flattening, and social amotivation, so social withdrawal. Now, what we don't have is basically anhedonia. That's not in there. But if he had that, then we would have also been like in the NSA, the negative symptom scale 4. But these items seem to capture enough of the variance in order to give us a tool. And that's easy to ask, because you only have to ask 3 questions. 3 of the 6 items are purely observational. You hear whether the patient talks, that's alogia. You see how much of gesticulation and facial expression they have, and you listen to their speech. Are they disorganized? So you ask 3 questions. Do you hear voices, or do you feel things, see things that are not there? Do you feel somebody's out to get you, or are there cameras, or do you feel somebody can read your mind? And who have you seen since we last met? And did you do that? Did you seek out the social contact, or were you dragged along? So that's basically it. And with a very pointed, short interview, you can get information that is as good as PANSS 30 in several studies that we've compared the 3. So that's one possibility of having measurement-based care for schizophrenia. And here's just one study showing that the difference in haloperidol, Sertindol versus placebo worked in PANSS 6 as well as PANSS 30. And we did that. Next slide. I don't know how many of those I put in there. This is the KD study, where we also showed clozapine is better than the rest, just with 6 items. Although clozapine is not the best for negative symptoms, but again, it replicated the data from the PANSS 30. Next. And then we have the problem now that when a patient comes to a clinic, they don't come in package. I have schizophrenia, I have depression. Well, maybe you have schizophrenia and depression. What about anxiety? So which tool do I pull out of my drawer? I don't know this up front. I can't give them 30 or let's say even 10 scales for the 10 most common disorders. So that's where we came up with the idea of the TGI. There's the CGI since 1976. Guy et al. wrote this in the NCDO guidebook, which is the clinical global impression scale. There's one for severity, 1 through 7, and there's also one for improvement, but we're going with the severity here. And we thought this is very intuitive. 1 is not present, 2 is a minimal, 3 is mild, 4 is moderate, 5 is marked, 6 is severe, 7 is extreme. And we now wanted a transdiagnostic tool that with one tool you get the most important domains. And that's the TGI, the Transdiagnostic Global Impression Scale. And we are building or have built several components. One is the psychopathology, and we always do it in triplicate. It's the patient, the caregiver, and the clinician. Each can rate it. So depending on your setting, what makes sense. Obviously, the clinician gets maybe information from the patient or the caregiver. So the TGIP was the first one that we developed, but we also feel symptoms is just one thing. Then we have functioning, and we have satisfaction, which the satisfaction is only the patient because it's subjective, but not just satisfaction with different areas of life, but also with care. So you get the idea, is the psychotherapy working for me? Do I have a medication treatment? Do I like that? And we also have the TGI triple S, we call it now, which is symptoms, signs, and side effects. So somatic symptoms and signs, where we have side effects, and also we have the somatic problems because people with mental illness have a lot of somatic illness. So this is the TGIP. We ended up with 10 domains. We tested it with patients, caregivers, clinicians. Obviously, it's not perfect. We don't have all items in psychiatry, but it goes from normal, as I said, to extreme. Go to the next one. That gives you here now the hyper and the hypopole. On the left-hand side is the too muchness, positive symptoms, aggression, mania, addiction, the too muchness. On the right-hand side, we have too little. We have cognitive problems, depression, self-harm, and negative symptoms. And then on the in the middle, we have items that can be either hyper or hypo. You can have withdrawn anxiety, or you can have agitated anxiety, and you can have too much or too little sleep. So this is the 10 items on the TGIP, and we are using these web spider graphs in order to then create an individual visual map, a footprint. Go to the next slide. So again, it's a hyperpole on the left, positive versus negative, hostility versus self-harm, mania versus depression, addiction versus cognition. And next slide. And then we get the rating either from the patient, the caregiver, or the clinician. And again, 7, it's on the outer skirt, it's extreme. In the middle, it's normal. Well, that would be 1 basically. And you can see here, this patient just visually has addiction problems, positive symptoms, some hostility, and a little bit of cognition and negative symptoms. So here, the primary treatment goal is getting the addiction under control, hostility, and positive symptoms. And then we can track the patient, whatever treatment we decided on. Is it psychopharm? Is it psychosocial? What happens in the next visits? And we can just compare them. And the patient can take this home, or the caregiver, and see also how this changed. And here you see like an idealized patient profile where they have a lot of ballooned symptoms in different domains, and then they're shrinking, and the patient gets back to their own core and can hopefully also function better, which we would capture with the other domain of the TGIF for functioning. And they would then have also better better self-esteem and other self-rated well-being components.
It's interesting to see this ideal shape. I wish patients come in, fill in, and then the clinician just grab the patient and to match each one and see where we are.
But the matching is the point. So this measurement, you asked this before, measurement alone doesn't get you there. So yes, I have the symptoms, but I need to know based on this patient. That's what Minds and then also Mentra will do for MedLink Global. We will match to this patient hundreds, if not 100,000s of patient trajectories and say, the likelihood for this patient to succeed is giving this treatment first, and if this fails, then that treatment. And that's where AI comes in. That wasn't possible, what we did in the RACE study, because it was very pedestrian. We used our own knowledge and had like a cookbook in a way of an algorithm which was not informed by this individualization and personalization of the patient.
Yeah, the importance of timing.
Exactly, and this is now the pyramid where we have the psychopathology on the left. That's already published for all three components. We're now submitting soon the satisfaction and functioning scales together in order to drive this out faster. And then we called it adverse effects initially. Now it's somatic symptoms and signs, which comes last because it was too complex. We wanted the patient to also rate their side effects, and the patients and clinicians came back to us far too complicated, so we have to revamp it. And then we're validating these scales right now also in a study. So this is the plan to have the psychopathology, the functioning, satisfaction, symptoms, and signs. So I think we can go further. So just last chapter before we close. Obviously, this all sounds great, but how can we have the rubber meet the road, that it actually happens? Next. So there's literature on that. It's called implementation science. And people in the audience may actually know that the gap between innovation and implementation is about 17 years. It's really horrible in medicine. And we need to shorten this. Now with AI and technology and digital health, I think it goes much faster. And we're trying to accelerate this in 3-4 years, that we basically have achieved our goal that most people will get precision psychiatry with our mantra, and that's based on minds. And hopefully this can be implemented in multiple medical records. It's already in Athena Health. It will go into others. But the terminology and core components of what is a good outcome, what's a bad outcome, which change mechanisms are there, and then also it's always the tool. Does the tool map onto A, the symptoms, B, the relevance for the patient, C, the relevance for society or the clinician, D, is it mapping onto also mechanism of action of the treatment. So all of this is very, very complicated. And does policy support it? Will people pay for it? Because we're now also measured on our performance, and that is usually how many patients you see. That is a bad measure. You can see many patients and they all do poorly. They kill themselves. We need to have basically outcome-driven performance measures, and that's payment for performance. And the more we get that, I think the more measurement-based care will be adopted, because insurance companies will not pay the same amount for each visit or day in the hospital unless it yields a certain outcome. And the outcome will not only be symptoms and hospitalization. I think in the future it will also be functioning. Yeah, so let's conclude, because we're already 45 minutes, and see whether there are other questions from you or the audience. So we must take measurement seriously. We need to take advantage of it, and not just in physical care, where people who step on the scale to measure their weight, or when they feel hot, use the thermometer. We need to do the same when we feel there's hot emotion. What does it mean when there's cold emotion, when people are flat? So in randomized trials, MBC was able to succeed. These are initial trials. They're not easy to do and to fund, because that's implementation. It's not hot and sexy, because you can't sell it in a way that you basically have. It's not a medication. The medication is just a tool. So in that sense, measurement did help both efficacy and safety. Next. So guidelines recommend it, but don't give us the tools, and they're not implemented in usual care, and they're also not paid for. So COMPASS did work in this study that we did for schizophrenia, and the PAN-6 may be one tool for psychosis, but maybe the TGI barrier platform may also overcome the barrier of not having the right tools for the right patients. And being transdiagnostic, it gives us one tool that can be applied to anyone coming through the door.
Thank you so much, Christopher, for having such a rich context and insights in this session. So I have like 2 more quick questions. The first is, it seems like measurement-based care is starting as a philosophy that has been proven that can helpful and very helpful during multiple research. Would you say that now with this distinguishes from a philosophy to an actual clinical care side is really to simplify and fast forward the implementation and become actually a workflow issue compared to buy in the philosophy. Everybody seems like agree and they know it's more than useful, right? But now it's facing the reality that is more like a workflow question, and you can, like the audience who either they're startup founders, investors, or clinicians. So when they need to put efforts from today on, would you say that effort should be on the implementation in workflow side?
Yeah, so you're entirely right. I think it goes from idea to tool to action, and that's implementation. So we are building tools at the moment. So the middle part is also important, whether it's the PAN6, the TGIP, or MINDS that we're using together with Delphia, who's completing the intake and the questionnaire, the interview, and whether it's Mentra. So we need to also build the right tools that are safe, that don't hallucinate, that keep the data HIPAA compliant, and that also gives outputs to patients and clinicians that matter. And then we need to integrate that into the workflow, that it's not too cumbersome, that everybody feels they're empowered, and also time is ultimately saved, cost is saved, and care is improved.
Yeah, and we have covered all the good things about measurement-based care today. What would you say the cost of not the cost of using it, because it can be many different pricing or challenges, but the cost of not adopting measurement-based care, what would you say from different party?
Well, I would say the cost is that you most likely have worse outcomes, and the life is usually reinforcing. When you're smiling, when you have a vacation, when you're in love, things go very well. Well, when there's a little bit of a problem, and then it rains, and then it's cold, and the person is shouting at you, things really get out of hand. I learned that in surgery, where they had, when I was in training, when they had perfectly running surgeries, they were so easy. Even trainees could do it. But the problem was when an issue arose. It's not the cookie cutter, oh, I give you 20 milligrams of let's say, escitalopram, and everything will be fine. But patients are complex. They're not responding to this. Something else happens. Then now the expert is needed. And it's not like gut-based. I need to know, I need to have a compass. Where am I going? And I haven't seen 1,000 patients like that. But our mentor will have seen it. So I think the cost is that we're doing a shotgun approach, or a shot in the air. We don't know what will work. It's trial and error. And that is not only in itself more error and trial than success, it breeds lack of success, because the longer patients are sick, the more unsuccessful treatments they've had, the next one will not work as well. The brain is a learning machine, but we are also learning machines. We're basically becoming more negative, hopeless, see ourselves as mentally ill, and are more removed from friends and work, and that becomes a downward spiral. So in that sense, we really can't afford not using measurement-based care, not now pairing this with the AI time zone that we're in right now in order to make it even more powerful.
Well, I think that's conclude for today's session and for a great first New Year webinar. So I will say thank you to the audience again, and we will see them next month.
Thanks, Ryan. Great discussion. Thank you all for watching. See you next month. Bye.